Okay. Today, we're going to talk about the mechanical system of the heart. We only have two topics to really cover, which is good. Well, one of them is high blood pressure, something that I'm sure you'll be dealing with every day if you don't already have it yourself. And the other side, the other aspect about that is heart failure. There again, oops, I'm going to change my pointer into a pen so I can terrorize you with all of the writing. Let's change that to black because it seems to show up better. There we go. Better. Keep an eye on this guy. He'll tip you off as to what might be on the test. We're going to talk about high blood pressure, left side heart failure, and right side heart failure. Some of you may have heard the term CHF. I use it a lot myself. It's unfortunate, but it's an old habit. CHF stood for congestive heart failure, which usually applied to left side heart failure, which is the most common, but we're trying to get away from that term now and specify left side or right side heart failure. Perfusion, passage of oxygenated capillary blood through the body's tissues. You've seen that before, haven't you? So let's start. What is high blood pressure? Let me get my box out of the way here. There we go. As you probably know, the normal blood pressure that you've been taught, what have you been taught was normal blood pressure? Was it 120 over 80? That's pretty much what I was taught, was 120 over 80 was normal. But they've since lowered the standards, and now they call 120 over 80 pre-hypertensive. So that's why I have this big question mark here. I'm not sure I agree with that. 140 over 90, though, is usually the standard for determining whether somebody has high blood pressure. Now, in the old days, I was taught 140 over 90 was pre-hypertensive, but they've since lowered the standard a little. I'm not sure I agree with that. But if it's 140 over 90 or above, then the person could be classified as hypertensive. Now, there again, having hypertension is a medical diagnosis. I don't want to see hypertension on anybody's care plan sheets. That is a medical diagnosis. Only the doctor can say that. There is a nursing diagnosis that incorporates high blood pressure, but I can't remember off the top of my head what that was. There's something else I wanted to say about that, and I just forgot what it was. Oh, it'll come back to me. Anyway, there's basically two kinds. There's essential hypertension, or we also call it primary hypertension. This is the high blood pressure that most people have. And it's just one of those that you wake up one day and you got it. I didn't know I had high blood pressure until I was working on a medical helicopter, and I had to go in for a flight physical. Don't know why, I wasn't flying the thing. But when I went in for my physical, they discovered my blood pressure was high. So I had to go to the doctor and get some medication to keep it down. Most common cause of essential hypertension is genetics, but we'll talk about that in a moment. The second type of high blood pressure is secondary. That's when you actually have a disease of some type that's causing your high blood pressure. As you will see when you get to Med-Surg 2, renal disease, when your kidneys begin failing, you retain fluid. Retaining fluid can increase your blood pressure. Certain drugs can cause high blood pressure, but we're going to go, we'll talk about a couple of those further on. So there's primary and there's secondary. Might want to remember that. Something I wanted to say about high blood pressure, but now I can't remember what it was. Anyway, moving on. What's the problem with high blood pressure? Well, when the blood pressure gets too high, it can destroy the small blood vessels. This is very similar to diabetes. Diabetes is the sugar in the bloodstream that's causing damage to the capillaries. With high blood pressure, it's just the pressure in the veins that are causing damage. And the most common of those is the kidneys. People with high blood pressure risk kidney failure. The number one cause of kidney failure is diabetes, and the number two cause of kidney failure is high blood pressure. So it's very important that people keep that high blood pressure down. And it can also lead to left ventricular hypertrophy. This is also the same as left side heart failure. And we'll talk more about that when we get to the left side heart failure. But basically, the added pressure in your system from high blood pressure just makes your heart work that much harder. And the heart is a big rubber band that keeps pumping blood out to the body. And when you put too much pressure on it and stretch it for too long, it gets hypertrophic, or it gets stretched out of shape. It's another way to put that. We'll talk more about that in left side heart failure. Data collection. What are the risk factors for essential hypertension, primary hypertension? There are basically two categories: those you can't control, and those you can. Non-controllable family history. This is the category I fall in. My father had high blood pressure. My brother had high blood pressure. My grandfather probably had high blood pressure. It's just genetic. It's in your DNA, and not a whole lot you can do about it. There is more prominent genetic factor in African Americans. African American males especially are at high risk for high blood pressure. And then as you get older, your veins or your arteries just lose their flexibility, which can increase your likelihood of developing high blood pressure. Did anybody have a question on that? Nope. Okay. Stuff you can control. Weight, obesity contributes to high blood pressure. Your body has to pump that much harder to get the blood through the system. Controllable, there's a lot of argument back and forth about how much control someone actually has over their obesity and genetic factors and all that. But if the person can control their weight, they need to do that. Smoking and stress will increase the likelihood of high blood pressure. I think it's an increase in cortisol that's what causes that. Sodium, everybody always talks about low sodium diet for those people on high blood pressure. I don't know if you've gotten it yet in fluid and electrolytes. If not, you will get it when we talk about the kidneys. Sodium and water go together. They are marriage made in heaven. If your body has a lot of sodium, your body is going to have a lot of water. If your body has low sodium, your body's going to have low water. The two go together. And when you're processing your blood through your kidneys, if your body feels like you have too much water in your body, it'll get rid of the sodium. It'll spit it out into your urine, and the water will follow, and it will lower the amount of water in your system. So when you go out and you have 3 bags of potato chips, fries, and a real salty diet, you're putting more sodium in your body, you're retaining more water. And that's why they tell people on high blood pressure, don't eat so much salt. Americans in general should not eat as much salt as they do, because we have a high salt diet, high salt, low potassium, and it's not healthy. Excessive alcohol intake can also cause high blood pressure. That usually relates to the liver. I'm just going to lightly touch on that one. Moving on, I don't know if you'll find that in your textbook or not. That actually from personal experience. I've seen alcoholics have a tendency to develop high blood pressure. Moving on. Might want to look at those. Secondary hypertension. There again, kidney disease. When your kidneys can't get rid of water, your blood pressure goes up. And when your kidneys fail, you can't. People in total kidney failure, they don't urinate at all. Their bladder just shrinks up to nothing. And that's why they have to go to dialysis, because dialysis is the only way to get the water out of their body. So you can imagine that's why they get high blood pressure. And it's usually heart failure that kills dialysis patients. More about that in med-surg too. Cushing's disease. Cushing's disease is where you just have a high level of cortisol. And Cushing's disease is also called hypercortisolism. Cortisol is a steroid. It causes all kind of nasty bad effects on your body. It causes you to develop fat deposits on the shoulder and the neck, causes you to gain weight. And the same is true of corticosteroids. The most common corticosteroid that we're probably familiar with is prednisone. Anybody who's ever had to be on prednisone for a long period of time, it really messes with your body. And when the cortisol levels go up, so does your blood pressure. High levels of estrogen can also cause that, and pregnancy. You will talk more about the hypertension you get during pregnancy because it's called something else. And I just totally forgot what it is. But there's a form of pregnancy that women can develop during pregnancy. It usually lasts during their pregnancy and goes away after the pregnancy or after the birth. And there's a name for it, and I can't remember.
Preeclampsia?
What's that?
Preeclampsia?
Preeclampsia is when you start getting high blood pressure during the birthing process, but Rachel hit it, gestational hypertension. Correct, thank you. Of course, I can see by the picture you've had a baby. Gestational hypertension.
I have 3.
Oh my God. So you'll talk more about that in OB. So I'm not going to hit on that. Just be aware that that's one case where somebody might develop high blood pressure. And since these things are causing the high blood pressure, that's why we call it secondary hypertension. Now, what would you expect to find for somebody with high blood pressure? These may occur, they may not. And that is why they call high blood pressure the silent killer. People can walk around for years and never know they have high blood. I did. I walked around for years and I had no clue that I had high blood pressure. And that is why people need to get into the doctor and get their blood pressures checked. Or even if you're walking through Costco and you got one of those silly blood pressure machines, people need to keep track of their blood pressure. Because if you don't control it, it can cause a lot of damage to your body. But if you become aware of it and you get diagnosed and you get the medications and keep it down, you can prevent all that damage from happening to you. So it's a preventable, or it's a disease we can treat. I won't say it's preventable, but it's a disease we can treat. Sometimes if people's blood pressure is really high, they may get headaches, fatigue, and dizziness from the additional pressure in the body. Nocturia, now that's the body's reaction to the high blood pressure. Since the body's trying to control it, you'll pee a lot to try and get the fluid off your body to get your blood pressure to go down again. And the nocturia just means you're getting up several times during the night to go to the bathroom. Polyuria could also fall in that same category. So if you're peeing a lot, it may be your body saying, hey, I'm trying to get rid of this fluid. Go get your blood pressure checked. Remember the silent killer. You're going to hear that term thrown around a lot out in the world. Like we're not in the world, right? Okay, whatever. Laboratory tests. There really is no laboratory test for essential or primary hypertension, other than just get your blood pressure taken. That's it right there. However, if you have secondary hypertension, these tests can tell the doctor maybe why you have high blood pressure. If your BUN and creatinine are going up, it indicates your kidneys are failing. That can tell him why. And that's what's so wonderful about vital signs. Vital signs give us clues. They're little arrows that point us to where other problems may be. If you go to the doctor and the doctor, BUN and creatinine may not be a test that your normal primary physician would give you, but you go to the hospital or you go to your doctor and he takes your blood pressure and your blood pressure is high, he may start looking around for other things and he may run a BUN and creatinine and find out, oh, you have kidney problems. Now, usually if you do, it's a result of having diabetes. But that can also cause your blood pressure to go up. There again, you can get a cortisol test run. That's not something we normally do on a regular exam, but if you have high blood pressure, that's something the doctor may look at. And you may have Cushing's disease and not realize it, or too much prednisone or whatever. So these are tests that are good for secondary hypertension. There really is no test for primary hypertension, other than just take your blood pressure. It's the easiest test you can take, right? EKG and chest x-rays, these are real late in the game. This is after the high blood pressure has already done its damage. You can see an overextended heart on a chest x-ray. And I'll show you that when we get to heart failure. ECG, if your heart gets stretched out of shape, there again, cardiomyopathy. Just based another word for your heart being stretched out of shape. It's going to change your EKG reading a little bit. So they can usually, with an EKG, that will give the doctor a clue. Okay, Eunice, you have to put your mute on. Eunice? Oh, thank you. If the doctor does suspect any of these changes at all, he's going to send you in for a cardiac ultrasound, which I'll talk about on heart failure. And that's where you get a really good picture of what the heart's doing. Patient-centered care, what you need to do as a nurse. One nursing diagnosis for people with high blood pressure is mostly knowledge deficit. I mean, there's really not much else you can do with these guys except make sure they know what the risk factors are for high blood pressure. Remember those, smoking, obesity, diabetes, etc. Discuss those risk factors so that they can hopefully get rid of those risk factors, reduce the salt in their diet, etc. If they do have high blood pressure and the doctor puts them on medication, you want to educate them about the medications. And we're going to talk about those here in a minute. There are certain things you can do and you can't do on certain medications. And the person needs to know that information. Also encourage them to exercise, encourage them to have a proper diet, and to monitor their blood pressure at home. There are a lot of these little portable blood pressure cuffs you can buy at Walmart and Amazon that automatically take your blood pressure, and you need to keep an eye on the blood pressure in case the medication is not working. Now, when it comes to medication, it's unfortunate. I'm going to scare the daylights out of you. Yes, there are 8 medications there, and that's just the drug families. There are a lot of medications out there for high blood pressure. And once upon a time, I had a little chart that showed how the doctors prescribe them. You know, they'll start out with a diuretic, then the next level is to go to a calcium channel blocker, and then the third level is an ACE inhibitor, et cetera. But for the life of me, I cannot find that chart anywhere online. I should have printed it while I have it. And maybe or maybe not, the doctors may or may not follow that hierarchy. Hopefully I can find it again, but in general, the doctors will always start with a diuretic. And the reason they start with a diuretic is because it's the least invasive, it's got the least side effects, it's the easiest on the individual. As hopefully, just by giving them a diuretic, it'll keep their blood pressure down to an acceptable level. Now, they'll probably never be 120 over 80, but if you can get them to like 130 over 90 or 130 over 85, That's good. I remembered what it is that I wanted to tell you about high blood pressure. You have the systolic and the diastolic number. The top number, the systolic number, that will fluctuate with stress, exercise, things like that. So 120, 130, 140, somebody might be 120 on most days, but then their boss yelled at them at work. So now they're 130 or they're 140. That top number is going to fluctuate. The bottom number doesn't, the diastolic. And that's the number we really keep an eye on for diagnosing people with high blood pressure. If they're 140 or 150 or over 80, they are probably just under a lot of stress. But if they're 120 or 130 over 90, that means their blood pressure is creeping up and they're risking hypertension. So that bottom number is a very important number when it comes to diagnosing high blood pressure. But getting back to medications, we try to start with the least invasive and then move on to the stronger stuff as we go along. The reason I have these right here highlighted is because these are 4 of the most common. So I want you to know a couple of those because you're going to see these in your clinical setting every day. These are drugs you will see every day. Probably 2/3 of your patients will be taking them. These others here, like the angiotensin and aldosterone antagonists, and these guys right here are not as common. So, I'd like you to look over them and just kind of familiarize yourself with them a little bit, but I'm not going to expect you to know a whole lot about these other 4. But the diuretics, calcium channel blockers, ACE inhibitors, and beta blockers are very, very common, and you're going to see those every day. So you might want to get familiar with them. Let's look at them individually. Diuretics. There's a couple different types of diuretics. You're going to get pharmacology next quarter. You'll be going over these more thoroughly. A very common medication for high blood pressure patients is hydrochlorothiazide, which we also call HCTZ. With a name like that, you can see why we use the abbreviation. It's a thiazide diuretic. Don't sweat about what does that mean. It's just a diuretic. Diuretic causes your body to lose water. That's all a diuretic is. It's a water pill. You'll hear this patients all the time talk about, I got to take my water pill. That's because this drug makes you pee. That's the bottom line right there. The most common is furosemide or Lasix. A lot of people take Lasix. In pill form, in the ER, we use Lasix a lot in liquid form to treat heart failure patients, and I'll talk about that later. Now, the thing about, and the way, remember I said sodium and water go together? What Lasix does is it makes your kidneys, it doesn't make your kidneys lose sodium. What it does is it prevents your body from reabsorbing the sodium when we get to kidneys, you'll see how that works. So don't worry about that right now. But basically, it makes your body get rid of sodium, which makes your body get rid of water. But at the same time, both the hydrochlorothiazide and the Lasix will also make you lose potassium. Very, very, muy importante right there. Very important thing to remember. When you think Lasix, think potassium loss. Now, the exception there is a little drug we call spironolactone, which you will also see. And spironolactone is a potassium sparing diuretic. So it makes you lose fluid without losing potassium. So this guy's the exception right here. A couple things to watch for with these drugs. Keep a close eye on the potassium. Now, that also applies to spironolactone too, because since it spares the potassium, somebody's potassium may get too high if they're on spironolactone. It's usually not the case, but if somebody's been on HCTZ or Lasix for a while and they're losing potassium in their labs, then the doctor will probably switch them over to spironolactone. Also, for all diuretics, you're losing fluid. So, keep an eye on their blood pressure. They do stand a risk of dehydration because you're getting rid of water, right? So not a real harmful drug, not a lot of side effects. So that's why it's a good first step for people with high blood pressure. Moving on to the next one. Remember, Lasix, potassium. Calcium channel blockers. Calcium channel blockers by altering the amount of calcium going into the cells, it causes the body's blood vessels to vasodilate. And there's a couple ways to lower a person's blood pressure. One is to give them less blood, but you don't want to get rid of red blood cells. You want to get rid of the plasma or the fluid. And that's what the diuretics do. They get rid of the fluid. The other way to lower somebody's blood pressure is to just make the plumbing bigger. If your blood vessels expand, it drops your blood pressure. It's just basic physics. So by getting your body's blood vessels to vasodilate, it'll drop your blood pressure. And a lot of these drugs do that. A lot of these drugs are cause vasodilation. But they do it in different ways by affecting different hormones in the body and such. So this one just happens to work with the calcium to cause your blood vessels to expand. A couple side effects, you may get a little constipation with these. Verapamil is the most common, and diltiazem or Cardia. Those are the most common of those drugs right there. There again, if you get too much vasodilation, your blood pressure can drop too much. And that's true of all the blood pressure medications here. If you might drop the blood pressure too much, you got to keep an eye on that. But what's unique about this is this and a couple other drugs, grapefruit amplifies the effects of the drug. So we don't want that. We want the drug to have a consistent effect on the body. We don't want to eat or drink anything that's going to alter what that drug does. And grapefruit, for a couple different blood pressure medications, I think lisinopril is another one, you need to avoid grapefruit and grapefruit products. A good general rule of thumb, if somebody is on high blood pressure medications, they should just avoid grapefruit. You're not missing that much out of life. I am. I really like my grapefruit, but hey, what the heck. Something to remember. Lisinopril. Now, this is an ACE inhibitor. And there again, it's working with a hormone in the body called angiotensin, which causes vasoconstriction. That gets a little confusing here, but if the angiotensin is causing your vessels to constrict, it's going to cause higher blood pressure. So by giving it an ACE inhibitor, we are stopping the angiotensin from constricting your blood vessels, thus helping your blood vessels to relax, thus causing that was interesting, causing vasodilation. So that helps slow your body. Very common blood pressure medicine, lisinopril. That's the generic name. Brand name is Zestro. And enalapril also is very common. So these two drugs you're going to see a lot in your clinicals when you start your clinicals. Like all the other blood pressure medicines, make sure it doesn't work too well. And you might get a dry cough. That's something that lisinopril is famous for, is you might get a dry cough from the medication. So people should be aware of that, because why am I suddenly coughing? No, it's the medication. Just keeping your throat wet, drinking water is the best way to prevent that. Here's there's another medication I'm not going to hold you to. You'll study these more when you get to pharmacology. Cozar, we sometimes see that a lot in a clinical, and is angiotensin 2 receptor antagonist, or more commonly called an ARB. There again, just like it stops angiotensin from causing vasoconstriction, just like the previous medication, angiotensin, vasoconstriction. It just does it in a different way, hits it in a different part of the cycle, but it's basically doing the same thing as lisinopril. This drug is kind of odd in that it'll sometimes cause angioedema, where you're swelling of the face and lips. If that happens, then the doctor will probably switch them over to a different medication. This also retains potassium, so you got to be careful that you don't eat foods that are too high in potassium, or your potassium level can get too high. Aldosterone receptor antagonist blocks aldosterone. There again, aldosterone doesn't constrict blood vessels. What aldosterone does is it retains sodium. And so when we stop that and it doesn't retain sodium, our body will get rid of the sodium and it'll help lower. Spironolactone is the most common one of those. It's actually a diuretic, but it also falls under this category as well. I would just remember spironolactone as a diuretic and not worry about this category. There again, avoid grapefruit products and check the potassium. Remember, spironolactone was a potassium sparing diuretic. Make sure the potassium doesn't get too high. Don't worry too much about this drug here. I'd rather you remember spironolactone as a diuretic. Okay, this is one you're going to see a lot. If it ends with an OL, it is a beta blocker. We have metoprolol, atenolol, propranolol. I could come out with a drug called brisolol. And brisolol, you would know, is a beta blocker because it's got OL at the end of it. Basically, the thing to remember about beta blockers, and I quiz people all the time in clinical, it slows down your heart rate. That's how it works. If your heart is beating slower, your blood pressure is going to go down. And it does that by blocking renin, which I wouldn't worry about remembering. But the thing to watch out for beta blockers is it can lower your pulse. That's why before you ever give any beta blockers to patients, you always have to make sure you look at their vital signs and see what their pulse rate is. If their pulse rate is 58 and you give them a beta blocker and their pulse rate drops to 48, they're going to get dizzy, fall down, they're going to go boom, and you don't want that. Normally, when you get up and you start hiking or running around or doing things, your heart will speed up to compensate, give you more blood to do your thing. When you're on the treadmill, you know your heart rate goes up to like 120, 130, 140. Well, people on a beta blocker, the heart is not going to compensate as well. So they jump out of bed, the heart does not speed up, their body consumes more oxygen, they get dizzy, they fall down, they go boom. So that's why you got to be very careful with your beta blockers, especially with your patients in the hospital. If they're taking a beta blocker and they jump out of bed to go to the bathroom, they could get dizzy and fall down. Now, when you pass out, the medical term for passing out is a syncopal episode. And you don't want your patients to have syncopal episodes because when they fall down, they get hurt. And when they fall down and get hurt, you have to fill out a whole lot of paperwork. So falls, we are very careful about preventing falls in patients. I would keep a special eye on my patients that are on beta blockers to make sure they don't jump out of bed or increase their activity too quickly. Sitting up and getting dizzy is also called orthostatic hypotension. Orthostatic meaning they're sitting up, and hypotension means the blood pressure goes in the toilet. So be aware of what patients are on your beta blockers because they may act a little differently during activity. Might want to remember that. Here's another one. This is kind of oddball. Clonidine. Yeah, it's out there. I see it given every once in a while. It's similar to beta blockers. It still slows your heart down. Just remember with clonidine, although it's not a beta blocker, just treat it as you would a beta blocker. Prazosin, I see that once in a while. There again, like the other drugs, it prevents vasoconstriction. In other words, preventing vasoconstriction means it helps your blood vessels relax. Watch out for hypotension. I don't see that drug a whole lot. So that's the drugs, just 4 of them that you need to keep an eye on, because you will see them every day when you get out to your clinicals. Client education. Not really a client, but the PCP should monitor electrolytes. Remember, we're dealing with sodium and potassium, and their levels are going up and going down. We need to keep an eye on the electrolytes, and who knows what blood test keeps an eye on the electrolytes. I don't think you guys have had that yet, have you? You'll have that in clinical 1, which is the second half of next quarter. We're going to go over the labs. But there is a basic metabolic panel, BMP, or a complete metabolic panel, CMP. You'll see that drug test a lot. That looks at all your electrolytes in your body. So you'll see that test a lot. Doctors run a CMP and a CBC on just about everybody that walks through the door. So make sure the patient understands the medications that they're taking and its adverse effects. If you're giving a patient instructions on the new beta blocker that the doctor just prescribed to them, did the doctor tell them about the activity, limiting activity? Probably not. It's going to be up to you to make sure that the patient is aware of what they can do and what they can't do. Do they have to avoid grapefruit? Should they eat high potassium foods or should they eat low potassium foods? That's all on you. All people, not just those on high blood pressure, should maintain a low sodium diet. Low fat diet, they believe that the fat and cholesterol contribute to high blood pressure. There's a lot of debate out there about that, especially on the low carb Atkins type diets. They'll argue with you on that. But the guy that designed the DASH diet, the doctor who designed the DASH diet, I can't remember what his name was pretty adamant about keeping a low fat, low sodium diet. And it does work. It does work. Sodium, keep it down to 2.3 grams a day or less. There again, all the other precautions, keep the weight down. Obesity contributes to high blood pressure. No smoking, reduce stress. Yeah, okay. Easy to do, right? Complications. Sometimes if the blood pressure gets exceedingly high, we could have some real problems. Now, exceedingly high, about 240 over 120. Now, somebody might have been walking around. He's 45 years old. He doesn't like to go to the doctor because guys don't like to go to the doctor. As you can tell, high blood pressure is more common in men than it is in women. And so one day he goes to Costco and he gets his blood pressure taken on the machine. He's 240 over 120. Well, now he knows why he was getting a headache, why his vision was blurred. He may have episodes of nosebleeds. And when it gets exceedingly high, you can actually go into a seizure. This is a medical emergency, a hypertensive crisis. Somebody walks into the ER and their blood pressure is that high. We want to bring them back. We want to start an IV because we're probably going to give them some real powerful antihypertensive medicines. Nitroprusside is one, nicardipine, labetalol. These are all emergency drugs. If you ever work in the emergency environment, you will be exposed to those. Any questions on high blood pressure? That is something that probably at least 50% of your patients will have when you get out in the clinicals. So I'm sure there's some family members that have it. 1 or 2 of you may actually have it yourself. Most of your instructors probably already have it. Let's move on to heart failure. Now, high blood pressure can cause heart failure. In fact, that's the most common cause, but there are other things also that can cause heart failure. Heart failure basically just means your ventricle got damaged somehow. You got a broke ventricle. In the case of hypertension, where'd my thing go? Here it is. In the case of hypertension, the high blood pressure has stretched that muscle out. And when I'm talking to people about their heart failure, I use the example of a rubber band. You take a rubber band and you stretch it, it works just fine. But then take that rubber band and stretch it way out, and then bring it back and way out again, and really stretch that rubber band and bring it back together again. And what happens to the rubber band? It gets floppy. It loses its ability to contract. The same is true of muscles. If you cause additional pressure in the body, that ventricle is stretching larger than it should. And after a while, it loses its ability to contract. It gets floppy. And so as a consequence, the muscle cannot contract as well, and it reduces your cardiac output, which causes a list of problems. And I'll show you what those are. Another thing that can cause a damaged ventricle is a heart attack. If you get a blocked blood vessel and it cuts off oxygen to an area of the heart and that muscle dies, you have dead muscle tissue in the heart. And so instead of the ventricle contracting nicely, there's this dead spot in the heart. So your muscle is not contracting efficiently, thus resulting in decreased cardiac output. Pulmonary hypertension, when you have diseases like COPD, causes extra pressure to back up into the right side of your heart, thus making your right ventricle overextend and stretch out of shape. So all these different things can cause those ventricles to get damaged. Now we divide it into right side heart failure and left side heart failure. And if you understand the mechanics of the heart, it'll make it real easy for you to tell from the symptoms of the patient which side of the heart is damaged. So let's go into that and I'll show you. Important thing with heart failure is there's damage to the heart, which results in decreased cardiac output. And y'all remember cardiac output from our previous classes, right? Stroke volume times rate times stroke volume. In other words, how much blood's coming out of the heart. Okay, what are some risk factors that may lead to heart failure? I'll break it down into right and left here in a minute. High blood pressure, which I just talked about, and that usually contributes to left-sided heart failure. Kidney disease, it's the same thing. The kidney disease is kind of just related to high blood pressure, because when you get kidney disease, you can't get rid of water. If you can't get rid of water, you get high blood pressure. Smoking and COPD kind of go together. These two are respiratory problems, and respiratory problems usually lead to right side heart failure. And I'll show you that here in a minute. Let's start with the left-sided heart failure. Now, we all know what the left ventricle does, right? The left ventricle pumps blood into the body. So anytime the body is not getting enough blood, we have these type of problems here. The left ventricle is not only pumping blood out to the body, but it's also receiving blood from the lungs, right? If you're not getting enough blood in your body, you're not getting enough oxygenation, you can be short of breath, dizzy. There's also another reason for dyspnea, difficulty breathing. I will talk about that here in just a second. Fatigue, because your body's not getting enough blood. The heart gallop, S1 and S2, lub dub. When one of the ventricles is out of shape, it's not keeping time with the other ventricle. So instead of lub dub, you have lub dub dub, because it's not keeping up with the right ventricle. So you actually are hearing two ventricles contract separately, which is what gives you that S3 heart gallop. Pulmonary congestion. Now, not only is the blood not getting to your body well, but since it's not pumping well, you're getting backup. It's like it's bad plumbing, right? Your ventricle is not pumping the blood out efficiently, but your right side of your heart's doing just fine. And it's pumping blood to the lungs. And then from the lungs, it's going into the left ventricle. But the fluid is backing up in the left ventricle because the left ventricle is not working well. So then the blood pressure backs up into the lungs. And what happens is the right ventricle is pumping all this blood to the lungs, but the blood's not getting out of the lungs quick enough, and the blood pools near the lungs. Now, what seeps into your lungs is not going to be the red blood cells, because the red blood cells are big, but the plasma in your blood is going to seep into your lungs, and you end up getting fluid in your lungs. And that causes pulmonary congestion. And that's why we used to call left side heart failure CHF, congestive heart failure, because you would get pulmonary congestion. But there's some other things that can cause pulmonary congestion too. So that's not really a good term. Left side heart failure is better. But if you'll hear people talk about CHF all the time. In fact, the doctors still use that term. Now, since you have fluid in your lungs, you can actually cough up the fluid, and it's a frothy sputum, and it's usually red tinted because there's a little blood in it. So if you have somebody coughing up like a red, pink colored foam, they have pulmonary congestion, probably from left-sided heart failure. And that is why when you listen to heart sounds, when you're doing your assessment on patients, listening to the base of the lungs. If you're listening to the base of the lungs and you hear this bubbling sound like fluid, they have basilar crackles. They have fluid in their lungs, probably from heart failure. And we probably need to give them some diuretic to get some of that fluid out of their body. Now in the ER, when somebody came in with congestive heart failure, our primary treatment was large dosage of Lasix. We gave them Lasix to get the fluid out of their body, and that would help get rid of the fluid in the lungs. The lungs would eventually pass the fluid on, and their blood pressure would come down, the fluid in their body would go down, and they would get back to normal. But for left side heart failure, Lasix was the go-to drug. Now, contrasting that with right-sided heart failure. As you know, the right side of the heart, the right ventricle pumps blood to the lungs. So anything that prevents the blood from going to the lungs can cause right-sided heart failure. So usually it's respiratory things, COPD, smokers. People like this are the ones that get right-sided heart failure. Now, your blood is coming back up into your body and coming in your inferior vena cava, your superior vena cava, and into the right side of your heart. If the right side of your heart is not working well, that blood's not getting back to the heart, right? Which is going to cause, again, a plumbing problem. The blood's backing up. And when it backs up, it causes edema. Now, edema is, most of the time it's in the feet because gravity works. Person stands up, they have excess fluid in their body, boom, it's going to go down to their feet. So when you see these big swollen feet with number 2 and 3 and 4 plus edema in the feet, it could be as a result of their right-sided heart failure. Also, the additional pressure will cause JVDs, jugular vein distension. They look like this, they turn their head and you can actually see their vein pulsing. Liver enlargement, alcoholics, it's very common for them to get right-side heart failure as well because the liver enlargement causes a backup of blood. In saying that, you will also find dependent edema in the left side heart failure patient as well. Pitting edema in the feet and basilar crackles are classic examples of congestive heart failure or left-sided heart failure. Now, how do we know which is which? Well, we can tell kind of by the symptoms that they are exhibiting. Laboratory tests, there's really not a blood test that tells us that somebody has heart failure. It's a mechanical problem. It's not a blood problem. But there is a peptide released from the heart called natriuretic peptide. I never can pronounce that right. This might give us a clue that they have heart failure, but it's not a real concise test. It's a mechanical problem. It usually requires a diagnostic test, like an ultrasound, to see if they have. I'm not going to talk too much about this. This is a common term for this invasive procedure is called wedge pressures. And we run this IV up into the heart and it measures the pressures in the various chambers. As you can see, it can measure in all 4 chambers. Now, these in the ICU world, we call these wedge pressures. And the wedge pressure can tell us which ventricle or atrium, how much pressure they are creating. And that is a whole science unto itself. If you go into the ICU, you can worry about that then. We're not going to worry about that. I just want to let you know it's there. This is the gold standard for diagnosing heart failure, left side and right side. It's an ultrasound. You go in, you lay down on a table, you lay on your side, and that guy takes that little ultrasound thing and puts a bunch of jelly on you and rubs it around. But the ultrasound will tell us what a person's ejection fraction is. And ejection fraction tells us what their cardiac output is. Now, normal people walking around the street, your normal ejection fraction is 55 to 75%. That's normal. That's a healthy heart. And that's telling us what percentage of the blood is coming out of the left ventricle and into your body. If the ultrasound shows that it's 40% or less, you have left side heart failure. Now, there's really 2 ways to determine heart failure. One is to look at the size of the heart, and the other is to see how much blood the heart is pumping out. But this is really the gold standard here. This is what we use to determine if you indeed have heart failure or not. The same is true. The ultrasound can also look at the ejection fraction from the right side of the heart. The normal is a little bit lower because the blood's only going to the lungs. It's not going to the whole body. And normal is 45 to 60. I don't know what indicates right side heart failure. I would guess it's below 40 or below 35%. This is the most common thing here. This is what happens to most people is left ventricular hypertrophy or left side heart failure. So this is the numbers you'll most likely come in contact with right here. Another way is chest x-ray. If somebody comes in the ER, they have basilar crackles, their feet are swelling, the doctor's going to do a chest x-ray because they're quick and they're cheap. And a radiologist can look at this and see, okay, here's the normal heart right here. Here is a hypertrophic heart right here. And as you can see, it's not real easy to see. That's why the radiologist has to read it. But if the heart's enlarged, it'll show up on the chest x-ray. And usually after they look at the chest x-ray, then they call the ultrasound guy. The ultrasound guy is on a portable cart. He comes out to the ER and he does the ultrasound on the patient to get a concise diagnosis. Any questions on that so far? We're going to go into the final step here and get you all done. Yeah, we've used up a whole hour now, haven't we? I always try to keep these to a half an hour and they somehow never work. Patient-centered care, daily weights. When you're in the hospital, they always have these daily weights on all these patients or the sniff. And you go, why are we always weighing these patients? Because if they get fluid overloaded, their daily weight's going to be the first indicator. If you have a renal patient, you'll be taking daily weights on that person several times a day, especially before dialysis and after dialysis. So although daily weights is a very common thing that we do all the time in the hospital and the skill centers, and people just kind of blow it off, it really is a very, very important diagnostic tool for the doctor. Keep an eye on your patient for shortness of breath, especially on left side heart failure. If they start getting fluid in their lungs, they'll get short of breath. You may have to give them O2 if they do. Oh, I didn't bring my water bottle in here. Oh, well. High Fowler's position. These people, when they get fluid in their lungs, it's easier for them to breathe sitting up. And the reason for that is you have a water. Let me grab the water bottle real quick and I'll show you what I'm talking about. This is how I always demonstrate it to my patients. Your lung is roughly shaped like this, right? And if you have fluid in your lungs, see it's along the bottom. I don't have fluid in here, but there's fluid along the bottom. You're covering a very small area. Well, when you lay down, what does that fluid do? It spreads out over a larger area. So when a patient is laying down and they have any fluid in their lungs, it's much, much harder for them to breathe. You know, this way you're covering a good, 25% of your lung. When you sit back up again, that fluid pulls at the bottom of the lung and you're only covering maybe 8 or 10% of your lung. So that's why people with fluid in their lungs find it so much easier to breathe when you sit them up. Possible bed rest. Yeah, these, if they're not breathing real well, they don't need to be getting up and walking around. What happens? They fall down, they go boom, you fill out a lot of paperwork. So daily weights are very important. Like I said, for people with congestive heart failure, we have to get the fluid off their body. And we do that with diuretics. Lasix is the most common. Unfortunately, with people that get renal failure, well, they're not peeing. So diuretics don't do anything for them. So if somebody is in dialysis, they probably will not be on a diuretic. For them, they have to go to dialysis. Okay, how do we reduce the workload of the heart? One of them is to get the fluid out of the body, which we do with diuretics. Another way to reduce the workload on the heart is afterload. Afterload is what the heart has to pump against. And so if we can reduce the resistance in the body, the heart doesn't have to work as hard. The way we do that is by lowering the blood pressure. Notice these are all blood pressure medications that we just studied for hypertension. So if we vasodilate the blood vessels in the body, then the left ventricle doesn't have to work as hard to push the blood into the body. So we're reducing their afterload is what they call it. Another way to make the heart work more efficiently is to just give the person a drug that helps the heart to work harder, increasing the contractility of the heart, helping the heart pump more efficiently. Digoxin is the most common. You'll see that. That's in pill form. You'll see that in the hospital and the nursing facilities. Dopamine and dobutamine, those are more emergency drugs. You'll see those in the hospital if someone's having an actual emergency. Those are IV and you don't go home on those. But ionotropic agents, if you ever see the word ionotropic, it increases contractility. That's what that word means. Beta blockers help the heart to relax by slowing it down. Now remember, if it ends with OL, it's a beta blocker. It relaxes the heart. In this case, you really have to watch the person's activity because you're relaxing their heart. They're not going to be able to get up and run around as well as they normally could. So those, and then vasodilators, but those other drugs were vasodilators too, but there are other things we can do to help the heart get more oxygen. In this case, nitroglycerin. Nitroglycerin expands the blood vessels in the heart and helps the heart to get more oxygen. So that's where, and you'll sometimes see those little tiny pills that they put under their tongue. We talked about that under myocardial infarction. So these are the various medications that we can give to a person who is suffering congestive heart failure to help their heart breathe better or to help them circulate blood more efficiently. Here are some of the other people that you'll be working with, taking Starbucks one. Yeah, but a lot of hospitals and places, you may or may kind of stuff. You can. There's no fix. Off of this is the missile. Saw a lot about that. I don't so much more. I don't know how successful it was, but I just don't see a lot of that. Now the cases and put them in the heart to help beat better. One of these, I have never seen one. I don't know how common these are, but they put this thing in the body right here. It goes through the wall of the abdomen, and it basically is a pump that helps the heart pump better. Like I said, I've never seen anybody with one of these, but I guess they're out there.
I've seen a bunch of them.
You have? Where is that?
Yeah, at Tacoma General and the CCU, that's where they install them. So anytime a patient has to go to the hospital, they have to get sent there.
Oh, really?
Yeah, they have to be in that unit. So they're always there.
They go straight to CCU then?
Yeah.
Do they carry this little shoulder pack?
They do. Some of them have like shirts that have pockets sewn into it. Some of them use a vest. Some of them have the shoulder packs.
Oh, cool.
It's pretty cool though. It makes like you don't hear a heartbeat when you listen to them. You hear like a mechanical humming song instead.
I've never assessed one before. That's like totally strange to me, but very interesting. Now here's the pump right here. This is what's pumping the blood. These other two devices, balloon pump and Impella device, these are emergency. These are when you end up in the ICU and they install them. You don't go home on these. These are emergency service devices. Back when I worked on flight helicopter, the balloon pump was the one that I came in contact with the most. And I don't know if I can, let me see if I can increase the size of this. There we go. Basically, well, I guess this is a portable one here, although I've never seen it portable. But what they do is we put a big balloon in the descending aorta. And this balloon coordinates with your heartbeat so that when your heart is relaxed, the balloon's inflated, forcing the blood to back up here in the ventricle. And then when your heart contracts, the balloon deflates. And when the balloon deflates, it reduces the afterload for the heart so that the ventricle can then pump the blood into the body. And then the balloon inflates again, pushing the blood further into the body. So it assists the heart with this balloon inflating and deflating in coordination with the heartbeat. Now, it seems that they've gone to the Impella device now because these are assistive devices to help the body to happen there. Go back. Okay. So these are just some devices you might see in the ICU. Now, if someone does have congestive heart failure, there are a couple of things that you want to educate them on. They still need to exercise. They still need to help that heart work and maintain your health. Just because you have CH or congestive heart failure now doesn't mean you can sit on the couch and eat potato chips. You still have to get out and exercise. Maintain a low sodium diet and limited calorie. Keep the weight down so your body doesn't have as much weight to push the blood through, and low sodium so that your body does not retain fluid. Don't smoke, don't drink excessive alcohol, and stay on your medication regime. These are the things you want to educate your heart failure patient on. Do we have anything else? Well, some complications to heart failure. If the heart failure gets extremely bad, you can get acute pulmonary edema. Now that's when you just got too much fluid back up in your lungs, usually from left side heart failure. Short of breath, fatigue, basilar crackles. If it gets too bad, you're not getting enough oxygen, you're going to pass out. So you need to call 911. Cardiogenic shock. This is more common with people who had a heart attack in MI. And that is you're just not pumping enough blood and you're going into shock. And you will do shock treatment for that. And we'll cover that another time. I think that's, I'm not sure where we cover that, but we cover shock in another module. And pericardial tamponade, very rare. I have seen it, usually with right side heart failure. Basically, you're just getting fluid around the heart in the sac, the pericardial sac that the heart's in. You get fluid in there and it can muffle the heart sound. And basically, the doctor in the ER will take a long needle and stick it up into your heart and draw the fluid out. But it can be life-threatening. That's an emergency. That's all I've got on heart failure. Any questions?
Bryce, I do have a question. Is it dangerous to initiate beta blockers pre-surgery?
That is a good question. And normally there are certain medications that the doctors will tell a patient to discontinue prior to surgery. And I think beta blockers was one of them. It's really hard for me to remember. I'm trying to think of what, I think the blood pressure medications were one of the medications that the surgeon would ask the patient to stop taking a week before surgery. I would have to look that up, but I believe that is correct. And I'm sure beta blockers definitely, because the anesthesia can slow your heart rate down.
Okay, that's what I wondered. Okay.
Yeah, that's a good catch. Yeah, and I would say definitely. There are the other medications that any anticoagulant medications, the surgeon wants the patient to stop taking at least a week or 2 weeks before the surgery, like Eliquis and warfarin, because they don't want excessive bleeding during the surgery.
Right. Okay. Thank you.
Sure. Any other questions on the material that I just covered? I will stop the recording.